Thank you very much. I now invite Mark Alberts to the podium. He will discuss collaboration and national quality improvement efforts in stroke. Mark?
Thank you very much for the kind invitation. It's a pleasure and honor to be here. I'm going to talk about stroke centers, a model improving cardiac care. These are my disclosures. You can see it's mostly unpaid stuff that I do. So my hypothesis is that a national network of cardiac arrest centers will improve the care and outcomes of patients with cardiac arrest. That's a hypothesis, but I think it's a provable hypothesis. I think we can apply the lessons learned from trauma and stroke centers to potential cardiac care centers. As you can see here, I think there are a lot of analogies between trauma, stroke, and cardiac arrest. They all occur without warning. They all have a time frame for intervention. They all require a multidisciplinary team to improve their care. And they all have somewhat similar, but again, somewhat different initial goals of care. But again, you can see that they have more in common than our differences. We know that trauma centers positively affect mortality. These are data looking at the presence of a state trauma system, that it reduces mortality. These are data showing that no matter how old you are, trauma centers reduce mortality. The challenge with trauma centers and stroke centers and cardiac arrest centers lies in their distribution, which you can see the distribution in terms of access to a level 1 or level 2 trauma center within 45 minutes or 60 minutes is uneven in different parts of the country. However, even though they may not live in immediate proximity, what you have tried to do with trauma, what we have tried to do with stroke, and what the challenge will be for cardiac arrest centers is to provide a system, develop a system whereby patients will at least have the opportunity to access higher levels of care. That's one of the challenges. Let's talk about stroke centers. We have abundant data now looking at primary stroke centers, that folks seen at a primary stroke center compared to a non-primary stroke center have reduced mortality. The amazing thing here, and these are absolute reductions, not relative reductions, is that you can see this difference in mortality beginning at 1 day, and it grows and persists and continues to get larger even at 1 year, which was quite dramatic. What about comparing outcomes in patients seen at a comprehensive stroke center versus primary versus a general hospital? Well, you can see here, if you look at outcome adjusted for patient demographics, looking at case fatality rate, it's lower at a CSC compared to a PSC, compared to a non-stroke center hospital. What about being home at 1 year? 22% higher at a CSC compared to a PSC, 16% higher versus the non-stroke center facility. So stroke centers reduce mortality and improve outcomes. These are obviously very important for our patients. So what are the lessons learned from the stroke center experience that may be translatable into cardiac arrest centers? Number one, as you've heard from several speakers this afternoon, is to assemble a multidisciplinary group with expertise and experience in the disease. This alphabet soup of organizations represents many of the professional organizations that make up the Brain Attack Coalition, including American Academy of Neurology, American College of Emergency Physicians, National Association of EMS Physicians, VA, surgeons, CDC, AHA, and many others. We have found the Brain Attack Coalition to be an extremely valuable and effective means by which to accomplish what we wanted to do. Now, in addition to that, the BAC has asked for advice and cooperation from major national other organizations such as CMS, the Joint Commission, FDA, and NIH. So they're not permanent members per se, but they assist and advise the BAC. So this provides the BAC with a certain level of gravitas, and it allows us to speak with one voice, which is very, very effective. So there are several advantages out of a BAC type of structure. We have instant expertise in all major areas. The recommendations have tremendous credibility right out of the gate. We have immediately buy-in from all of these major organizations, and frankly, there's no one left to disagree because we've included them all. So if they disagree, they're really disagreeing with themselves. Now, there are some disadvantages, to be fair with this. We do have a large number of member organizations. This can sometimes slow the decision-making and make it somewhat cumbersome. But again, at the end of the day, we end up with a product that everybody can agree with. We have had some disagreements among some of the organizations, and this can lead us to sort of the lowest common denominator. Well, we can't agree on all 5 of these things, but what 3 things can we agree upon? And that's an initial step forward. And again, you want to keep the process moving forward. Different groups do have competing priorities, which can sometimes be a challenge. So, the Stroke Center initiative led by the BAC has been amazingly effective. Since we started this in the year 2000, we have at least 1,500 primary stroke centers in the United States, about 250 comprehensive stroke centers. Most states now have a system of care. Most states now have some type of stroke triage or diversion paradigm, and that never would have happened when we first started this. So it's a long process. It's taken 16 years to get to where we are, but it has been tremendously effective and beneficial. How did we get this all done? Well, number one, we needed some verification that the stroke center was doing what a stroke center should do, that they were providing the staffing, the infrastructure, the care protocol, the expertise, and the outcomes 24 hours a day, 7 days a week. How did we accomplish this? The major big step was the Joint Commission came in and began a formal certification process. This was on-site as well as data-driven. It gave the whole thing instant credibility, because when you say our stroke center is certified by the Joint Commission, people take notice. They realize that there's a certain amount of gravitas, a certain amount of expectations and expertise involved in saying that. There was actually competition in cities and regions, because when Hospital A started marketing themselves as a Joint Commission certified primary stroke center, Hospital B said, wait a minute, we don't want to be left out here. What do we need to do to become a stroke center? So we thought that the paradigm was that a rising tide would float all of the boats, and that has largely been successful. Again, we have 1,500 primary stroke centers in the United States. Then other groups besides the Joint Commission began their certification process. These included HFAP, which certifies a lot of osteopathic hospitals, and DNV, which is a separate certification group. But at the end of the day, with all these different groups certifying hospitals as stroke centers, again, it increased the visibility, and we think it did improve the care. What about state designation? Well, after you had the Joint Commission verifying stroke centers, then the state would come in and designate certain hospitals as stroke centers based on the Joint Commission criteria. Then this motivated and it allowed EMS to bypass the non-stroke center hospitals. EMS wouldn't do that before just based on some hospital saying, hey, I'm a stroke center. But when you had this independent group come in and do it that then met the state criteria, then it happened. Then the next step was that you had state and regional triage protocols were developed. But even with that, we still faced some important hurdles. So what did we do to overcome these hurdles? Well, one of the hurdles was, again, there was concern about bypassing these non-stroke center facilities. Our EMS colleagues were very concerned about this. Well, when I was in Chicago at Northwestern, we actually did a survey of every hospital in the city of Chicago, asking them, would you mind being bypassed for stroke patients? A third of them, or about 30%, said, no, we're okay with that. We don't want EMS to bring stroke patients to us. We don't really care about stroke. It's not a real area of focus or interest. So once we had those data, it really alleviated and lessened the concerns of EMS about bypassing the non-stroke centers. I think the same thing could be due for the cardiac arrest paradigm. You may see some hospitals that have no interest in being cardiac arrest centers, either comprehensive or primary or whatever level you all decide upon, which is good to know. It's good for you to know. It's good for EMS to know, hey, we should not take our cardiac arrest patients to Our Lady of Hopeless Causes Hospital because they're not interested in admitting them. That's good to know. And I'm sure that there are some hospitals that would be happy to not have those patients. So another challenge, though, is that with all due respect to the EMS colleagues in the room, EMS has significant national diversity. In the state of Illinois, we had 16 different EMS regions, and within the state, there was tremendous diversity. And getting EMS to do the same thing is somewhat like herding cats. But what we did is that we empowered the local EMS agencies to say, if you don't agree with this protocol, that's fine. Develop your own protocol, report your metrics, just participate in the system. The main thing was to move the system forward. Don't let the perfect be the enemy of the good. Move the system forward. There were also concerns about overcrowding of specific hospitals and long transportation times. The marketplace took care of this. In big cities, you had a lot of hospitals become primary stroke centers because they did not want to be bypassed. And that sort of solved its own problem. You want to design a system with flexibility. Track your outcomes, change your protocol as the care paradigm changes. We had no idea when we published the Comprehensive Stroke Center paper in 2005 that we would have endovascular therapy for acute stroke in 2015. But now we do. And the whole system has changed to route those patients with the big bad strokes to the comprehensive stroke centers that are capable of doing endovascular therapy. And then look for opportunities to collaborate. We work a lot with Get With a Guideline Stroke and Mission Lifeline Stroke in those collaborative research things. So my proposal for the cardiac arrest community is to sort of model what we did with different levels of stroke centers. You can see here for stroke centers, we have comprehensive, primary, and acute stroke ready. For trauma, you have level 1, level 2, level 3. A proposal is that for CAC's cardiac arrest centers, you have comprehensive, primary, and perhaps initial. With different levels of expertise in each one of those, the experts in the room can define what goes in these boxes. But I've heard a lot about, well, what about out-of-hospital and in-hospital cardiac arrest and things like that? I think any designated cardiac arrest center should be able to provide a certain level of expertise, whether it's in-hospital, out-of-hospital, a visitor, somebody in the ED, whatever, and then maybe transfer the patient to a higher level of care. As you heard from the cardiac arrest survivor a few minutes ago, she was fortunate to have a bad-sounding cardiac arrest in a center that almost certainly would be a comprehensive cardiac arrest center that was able to provide all of these services 24 hours a day, 7 days a week. I think the challenge to you in the cardiac arrest community is to make sure that every patient, no matter who they are, where they are, maybe they cannot get that same level of care where they have their initial arrest, but that they have access to a system of care that will provide those resources to them, just as this young physician got her resources, as you heard about a few minutes ago. So let me conclude by saying that cardiac arrest centers make perfect sense to me. This concept have worked very well for trauma and stroke. There are many parallels in terms of the diseases and care paradigms. Setting up something like the Brain Attack Coalition to help focus and motivate this, I think, is an excellent suggestion. When the going gets tough, and I promise you, we had a lot of disagreements in the Brain Attack Coalition about how to move things forward and what to agree and disagree on, the question I always ask them is, what is best for the patient? Not for you, not for your organization. Tell me what's best for the patient. And whatever that answer was, that's how we move the system forward. This will guide you to the best path forward. Thank you very much for the kind invitation. It's been my honor to speak to you. Thank you.